Good evening and welcome to session 1 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. Thank you so much for joining us this evening. My name is Carrie Callis and I am the Director of Programs at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We typically have this event in person, but because of obvious reasons, we moved to a virtual format and we really appreciate you adjusting to this virtual setting. We would like to thank our supporters this evening, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs and resources, including our online support community and our comprehensive listing of resources. At this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff from Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation, as well as for moderating this program tonight. So I'll turn it over to you, Dr. Stiff.
So thank you all for participating. This is going to be saved and archived for future use, and you can review it back on the screens on your home computers or wherever you want to look at these talks and refresh your memories, etc. in the future. So without a lot of to do beyond that, I'm going to introduce Dr. Venugopal, who's chair of the Division of Hematology at Rush University Medical Center here in Chicago. He's been a long-time friend and a friend of the Leukemia Research Foundation. He's a well-respected blood cancer specialist and in all areas, but he focuses mostly on lymphomas and chronic leukemias. And he's going to speak first on updates in chronic lymphocytic leukemia and small lymphocytic leukemia.
Okay, so over the next 20 minutes, I'll be talking to you about 2 diseases, chronic lymphocytic leukemia, CLL, and small lymphocytic lymphoma, or SLL. Just like Dr. Stiff just told you about the similarities between, 2 of the diseases that are being presented today, the CLL and myeloma. These 2 diseases I'm going to talk about are very similar. In fact, in many of your blood report and pathology report, you will see SLL/CLL. And these diseases are very similar. They look very similar under the microscope. The cells have very similar characteristics where it is expression of proteins or chromosome abnormalities. And also in terms of treatment, it is very similar. So I'm going to focus my discussion primarily on chronic lymphocytic leukemia. And of course, we'll emphasize wherever something needs to be emphasized on SLL. And of course, I'll be able to answer the question at the end if you have any specific SLL questions that were not addressed. So the first few slides, I will talk about what we have learned in the past few years that is new, which helps us determine the prognosis and identify appropriate new treatment options. CLL, as you know, is the commonest type of leukemia above the age of 19 years. That's the commonest leukemia. It's a disease that is common in older individuals. And most of the time when it is diagnosed, the patient doesn't have any symptoms. And prognosis can be determined based on many things, including one of the very early staging system, RICE staging based on blood counts, enlarged lymph nodes, spleen, anemia, and low platelets. And if you look at the graph on the right side, it shows that in patients who are below 75 years old, all these groups, the survival is impacted by the disease. Now, this gives you an idea of how many new cases will be diagnosed in 2020 in the United States. So, in estimated number of new cases, about 21,000 plus. The good news is that majority of these patients live long. As you can see, 5 years, more than 86% of these patients are alive. The graph here, the green one represents the incidence of CLL. As you can see, in the last 10 years, the incidence has been coming down. The number of new cases has been decreasing. And this is the graph showing the death rate. That also you can see over the last several years and decades, the death rate has been declining slowly but steadily, largely because of our better understanding of the disease and better treatment options. How is the disease diagnosed? In simple terms, you go to a primary physician for a routine checkup, which is a very common situation, and the physician finds that your white cell count is slightly elevated, and he or she will say, come back after 1 month. You come back after 1 month, check again, the white cell count is still elevated. At that time, the physician may refer you to a blood specialist or a hematologist. The hematologist looks at your blood smear and sees these cells. These are the lymphocytes you see under the microscope. Then he does a variety of tests in the blood, which will tell the features of these. And the tests that are done are blood counts, of course, blood smear, which is what I just showed you, and a test called flow cytometry, which can tell fairly accurately the diagnosis of CLL in most cases. So the point is, for diagnosis and confirming the diagnosis of CLL, blood test is all that is needed. You don't need a bone marrow biopsy or CT scan or any other scans. What is my prognosis? That's a very common question that is asked once you have a diagnosis given to you. This will depend on a variety of factors, but some of the newer factors you should know when you talk to the doctor are listed here. CD38, ZAP70, these are proteins expressed on the leukemia cells. If they are high, they have a less favorable outcome. Similarly, you should know the status of the mutation of this is called IGHV mutation. This protein in the blood is an important one. The chromosomes and FISH analysis is routine, and you should know about your chromosome abnormalities, especially knowledge of these high-risk abnormalities is very important. And of course, gene mutation. So these are terms you should be asking your doctor. What is my chromosome study showing? What is my FISH showing? Is there any high-risk chromosome abnormalities? PCR, mutation analysis, and NGS is next generation sequencing. This is a study of the gene pattern of the leukemia cell. So these are some terms you should know when you talk to your doctor. Just to show you an example, if you look at the FISH results, if you have a 17p chromosome abnormality, these patients, disease progress very quickly. These are the patients who are surviving, and this is a time. You can see that this line goes down very quickly. That means the patient's disease progress very quickly if they have this abnormality. Compared to patients who have normal chromosomes, you can see that their disease progress very slowly. So it's very important to know chromosome abnormalities. What are the indications of treatment, starting treatment? Because most patients, when they are diagnosed with CLL, they don't need treatment, but the doctor will be watching you each time they see you to see if you develop any indications. Some of the indications are listed here, like if you develop symptoms, fever, night sweats, weight loss, or if you develop evidence that your bone marrow is failing because the CLL cells are packing the bone marrow, like anemia or low blood counts, like low platelets, or if your spleen or lymph nodes are getting very big, causing symptom. These are all indications of treatment. Now, one of the questions I received from one of you before the talk was, in this day and age when we have new drugs, should we still stick to these? The answer is yes. The point is, observation is appropriate in the absence of indication for treatment. So having said that, what are the appropriate options for treatment? First, we would look at the options of treatment for first line. Chemotherapy has been used for years. We still use it, but its use is very limited now because we have all these newer agents which have much less side effects than chemotherapy. Monoclonal antibodies are proteins like rituximab, which is known to most of you, but there are newer monoclonal antibodies which I talk about. You can combine these two and make combinations like FCR, BR. These are chemotherapy combinations we have used for a very long time. And of course, the new drugs we'll be talking about. Always remember, clinical trials are the best way to have an opportunity to get newer combinations of medications and newer medications. Always you should ask your doctor about clinical trials that are available. If you look at the new drugs that has come up in CLL treatment in the last 10 years, you have a variety of names here: Ibrutinib, Acalabrutinib, Ofatumumab, Obinutuzumab, Idelalisib, Duvelisib, Venetoclax. I'm going to talk about these in the next slide, so I'm not going to spend much time on this slide. So the first group I will talk about is the so-called monoclonal antibodies. You can see here, this is a leukemia cell, and these are the proteins that are expressed on the cell, on the surface of the cell. CD20 is a target for rituximab. Like rituximab, you have Ofatumumab and Obinutuzumab. These are newer rituximab-like drugs which are FDA approved. There's also a clinical trial drug which is not yet approved. The other group is so-called PI3 kinase inhibitors. These two drugs, Duvelisib and Idelalisib, they are oral drugs which are very effective. You have the so-called BTK pathway inhibitors, Ibrutinib, Acalabrutinib, and the more recently approved Zanubrutinib. Venetoclax is the inhibitor of the protein called BCL2, a very effective way of controlling the cells, the leukemia cells, and I will talk about that. And there are certain other areas which are being investigated, including CAR T cell, which I'm pretty sure you will be hearing more in the myeloma session. Let's look at the BTK inhibitors. This slide shows you the 3 BTK inhibitor drugs that are in the market. One is Ibrutinib, which was the first one to be approved, Acalabrutinib, and the more recently approved Zanubrutinib. Zanubrutinib is FDA approved for a lymphoma called mantle cell lymphoma. It's not approved for CLL yet, whereas these two are approved for CLL. Now, this is given once a day. Acalabrutinib is given twice a day, and this drug is given once a day or twice a day. There are some side effects associated with Ibrutinib, including irregularities of the heart, as well as bleeding, especially if you take it with blood thinners. Headache can occur in about a third of the patients who take this drug. And side effect appears to be less with this one, but we don't have any straight head-to-head study in CLL in these with these drugs. For example, if you take Ibrutinib alone without any other medication, you can see that the PFS, or progression-free survival, which means the time when your disease remains under control, is excellent. At 7 years, 83% of the patients have disease very well under control by taking this oral agent alone. And at 7 years, 84% of the patients are alive. This is overall survival. So very efficient. No question about that compared to what we were using before. Let's compare it to a chemotherapy pill we have been using before, chlorambucil. Ibrutinib works much better. This is again the progression-free survival, time it takes for the disease to progress when you are taking this drug. In the last year, the 2019, there were 3 trials, big trials, which influenced our treatment opportunities and treatment decisions in 2020. So I'll briefly talk about them. One is combination of obinutuzumab or Gazyva with ibrutinib or Imbruvica, showing that patients who receive that combination have much better outcome compared to patients who take the antibody and the older pill, which is chlorambucil. Even in patients who have high-risk disease like high-risk chromosome abnormality, this works very well. So this is the first non-chemotherapy combination that was approved by FDA, and that was in January of 2019. And here is a comparison of ibrutinib and rituximab with one of the most effective chemotherapy regimen we used in the past called FCR. What does it show? Ibrutinib combination with rituximab works much better in keeping the disease under control, and these patients live longer compared to patients who get chemotherapy. So clearly showing that the combination of this new drug leads to better control of the disease and patients live longer compared to standard chemotherapy. This one is again to show that the combination of bendamustine and rituximab, which is another chemotherapy we have been using extensively, compared to ibrutinib, as you can see here, ibrutinib or ibrutinib with rituximab works much better than chemotherapy BR, again showing the efficacy of novel agents. So ibrutinib and rituximab leads to better disease control compared to bendamustine and rituximab. This study did not show any overall survival benefit, but the disease control was much better. How about patients who came back with disease or relapsed CLL? Chemotherapy, antibody, and combination are still options. Ibrutinib, acalabrutinib, and Venetoclax are also options for these patients. Again, clinical trials should be looked into. Also, stem cell transplantation. As you know, stem transplantation is a very effective treatment. In CLL, it's not very often used because of many reasons, including the fact that many patients are older and have other diseases which may compromise their ability to go through an intensive treatment, whereas this treatment is still very effective and useful in younger, healthier patients who have high-risk disease, where even with the novel agents, their disease may not remain under control for a very long time. So this one shows comparison of ibrutinib with ofatumumab, a monoclonal antibody, clearly showing the efficacy is much better. And this one shows the efficacy of the second drug, acalabrutinib, compared to chemotherapy, does much better. Now, there are trials going on head-to-head comparing these two to see whether they are equally effective or side effects, are they equal, or is there a difference in terms of side effect? Now, we don't have this data. Similarly, there are studies comparing ibrutinib with the third drug, that is zanubrutinib. Again, this is ongoing. We will be looking forward to the results to see if there is a utility in recommending one of these over the other. So summary of BTK inhibitor, as I showed you, ibrutinib as well as acalabrutinib works much better than what is conventionally available with chemotherapy. So let's talk about Venetoclax, which is the BCL2 inhibitor. Venetoclax is an oral agent. Again, majority of patients respond to the treatment. Even patients who have this high-risk chromosome abnormality, majority of them respond to the drug. And this is a study where they showed that Venetoclax, when combined with rituximab, works much better than the standard combination bendamustine rituximab. So Venetoclax plus rituximab leads to better disease control compared to BR. Similarly, Venetoclax combined with the newer rituximab, obinutuzumab, or Gazyva does the same thing. It works much better than the standard chemotherapy rituximab or obinutuzumab combination. And this combination of Gazyva and Venetoclax or Venetoclax was FDA approved in May of last year. So with that, I'm going to conclude my talk with these statements. In the first few slides, I showed you that there has been a lot of developments in the understanding of the disease as well as prognostic factors, which are not only helping in telling the patient about their prognosis much more accurately, but also helping them in making the right choice for treatment. Treatment of CLL and SLL is more personalized now depending on the characteristics of the disease. And we have now non-chemotherapy options which have much more efficacy and much less side effects. And as always, I encourage you all to participate in clinical trial because that's the way people have developed these combinations, and that's the way we can look forward to newer medications and newer combinations. With that, I am going to conclude, and I thank you very much for your attention.